Hi guys, this is Cassandra. I'm going to be discussing chronic myeloid leukemia. The purpose of me selecting this topic was I do feel like that cancer is a pretty intricate topic that a lot of us are not very familiar with. So I think it would be kind of good to kind of delve into leukemia in general and then kind of discussing the particulars of CML. These are the objectives I've labeled here below. And then I also actually did include a peripheral blood smear of someone in advanced disease. I got this from Up to Date, and you can see the little description right here. For the sake of time, I won't be able to kind of go through everything because it is a very complicated disease process. So going back to the basics here, we are looking at hematopoiesis overall. If we can remember from A and P, we begin with these multipotent hematopoietic stem cells in the bone marrow that when they proliferate, they can either remain stem cells or they will go down these two pathways here. So we're looking at them becoming myeloid progenitor stem cells or lymphoid progenitor stem cells. Now our issue with CML lies about right here. The description and the variations of it, we can have an over-under proliferation of blood-forming tissues like the blast cells in the bone marrow or in other tissues, and their designation is dependent upon the type of cell that predominates and their rate of proliferation. So leukemia is broken down into four main types. We have the acute lymphocytic leukemia, acute myeloid leukemia, then we have the chronic side, chronic lymphocytic leukemia, and chronic myeloid leukemia. And again, what we're talking about is CML. There are various subtypes to all of these types as well, depending upon their particulars as well. Epidemiology, so leukemia does account for about 33% of all cancers. As far as CML goes, it does carry a male predominance. And the mean onset of age is 65, which is why this is a disease process we are discussing in this class. The only known risk factor is going to be ionizing radiation exposure. There is no familial disposition. But there are other potential causes, such as exposure to cancer drugs or other immunodeficiency disorders or chromosomal disorders as well. As far as the pathophysiology of leukemia in general, again, we're looking at a malignant transformation at the pluripotent stem cell level. There's abnormal proliferation, clonal expansion, and excuse me, and diminished apoptosis that replaces the healthy cells with malignant cells. These leukemic cells that are in this bone marrow space can actually suppress the normal hematopoiesis level, leading to additional complications. As far as CML specifically, we are looking at the translocation known as the Philadelphia chromosome. It's an abnormal pluripotent hematopoietic progenitor that excessively produces the granulocytes in the bone marrow, the spleen, and the liver. And there are three different phases within CML as well. So when we're looking at the clinical manifestations and the physical exam findings, initially when patients are kind of in this benign stage, it does have a very insidious onset. Symptoms are very nonspecific, very easy to look over: fatigue, anorexia, weight loss, and maybe even abdominal fullness. That can be due to the start of splenomegaly developing. Once they're in the accelerated phase of the blast phases, there are some more ominous symptoms. So we're looking at splenomegaly, pallor, bruising and bleeding, fever or low-grade fever, lymphadenopathy, and some potential skin changes. As far as the diagnostics go, it is more of an incidental finding on the CBC with differential. So these are the different variations we'll see. But again, specifically to CML, we're looking at an increased granulocyte count, less than 50,000 in asymptomatic patients, but between 200,000 to 1 million in symptomatic patients. We may have an increased platelet count, could be normal, but in accelerated disease, it is low. We're looking at anemia and in accelerated disease, high basophil count, which we saw in that initial blood smear. Also, too, we're going to do a peripheral blood smear that's going to differentiate CML between other forms of leukocytosis. There's also a blood draw known as the leukocyte alkaline phosphatase score. It's going to be typically low in CML, but it can be elevated in accelerated disease process. Then we have our bone marrow biopsy. We're looking at the karyotype evaluation. Myelofibrosis or sideroblasts may be seen on the microscopy, but confirmation of this diagnosis is going to be by finding the PH chromosome in samples examined with cytogenic or molecular studies. Now, I will also make a note that less than 5% of CML cases do not have the PH chromosome, and then additional tests can be done to confirm that diagnosis. So as far as treatment goes, we're going to be using our tyrosine kinase inhibitors and or chemotherapy, depending on where they are with their disease process. The TKIs may eventually be discontinued and the patient can remain in remission. It's doing some pretty good work. They're suggesting that eventually it could be considered even a cure for the disease. But the remission durability is unknown, but it is the most effective treatment in achieving it. The drug specifically used is going to be imatinib here. During blast crisis phases, you can use the TKIs plus chemotherapy for the most effective treatment. If these fail, we can go on to the occasional stem cell transplantation, excuse me. And then there are other additional therapies too in order to treat the symptoms of CML. These do not treat the disease, such as hydroxyurea, busulfan, or interferon. But since the usage of these treatments, survival has increased to greater than 90% at the 5-year post-diagnosis. But before that, median survival was about 4 to 7 years. So finally, we're looking at geriatric and APR impertinence and implications. Interdisciplinary team, we're looking at, we have to work with other specialties, especially because a lot of our patients are geriatric and will have other comorbidities. We may even have to involve family members in their care as well. We can use EHRs to communicate with our interdisciplinary team, support our clinical decision making since we have more availability to more up-to-date information. And we can even use telehealth to talk to our patients who may not have transportation, may be disabled, and cannot make it into us, especially in the older population. Treatment cost is another concern as well. Cancer treatment is expensive, and a lot of our older patients are on fixed incomes. And then also, too, we're in a pretty hot political climate right now. We don't know what's going to be happening with the coverage for Medicare and Medicaid for a lot of these patients. So this could really limit their access to treatment as well. Ethical decision making, in our older patient with several comorbidities, is it more appropriate for us to pursue treatment, or can we look at more palliative care? Depending on what their whole clinical picture is looking like. Also, end of life, do they value quantity over quality? What is it that they're looking for in our older geriatric population? Cultural diversity, of course, we need to respect the different cultural viewpoints of these patients, what it is that they value and what it is that their care plan goals are. Also, too, again, socioeconomic status, we need to be considering whether or not they can afford it, and how we can go about helping them in those case scenarios. So again, this PowerPoint was kind of long. It's a pretty intricate topic, so I did go over the time. I don't really think there was a way for me to kind of get past it, but these are the references used. So we've got our textbook for the course, also to this link with up-to-date. And then I also used a Merck manual that I had purchased previously with the most updated edition. So take a look at these if you guys want to learn a little bit more.